Welcome to the Unsigned Note. I'm Dr. Natalie Gentile, and every healthcare worker has a note that they never end up signing, right? The thing they want to say out loud. They're staying silent about issues that are hurting their patients and really destroying their careers. And so we are here to say the thing together. I am a direct primary care physician and family medicine doc, and I'm excited to be joined today by Dr. Jordan Emont. I want to hear all the things about you. Can you introduce yourself to our audience?
Yeah, thank you so much, Natalie, for having me. It's so great to be here. So I'm an OBGYN in the Bay Area, and I feel very excited to have this conversation because I kind of have my feet in two different worlds here, which is that I spend a large proportion of my time working at a community health center, folks who largely have Medicaid for insurance, many undocumented people, and, largely Spanish speaking population. And it's such a fulfilling, wonderful environment, but it also is a very burnout prone environment.
Mhm.
And then the other proportion of my time is spent running my own concierge telemedicine practice, which is focused on menopause and I would say, kind of like women's preventative health more broadly. And so I'm excited to have this conversation today because I think that we have a lot to discuss about kind of the role of physicians in our current system and, how we take care of patients in a way that is fulfilling for us as clinicians, that is providing the best care, but also that is sustainable over the long term.
I love that. And really what we're going to dive in today that makes this kind of secret special territory in the healthcare world is cash pay medicine, right? It can be this taboo topic that I think we need to discuss because it's being more and more talked about. And we also will talk about another challenging topic, women's health,
Yes.
and the intersection of those two things. So I want to set the scene really what led us to this conversation and connection in the first place, which I'm so happy to make. There was a Threads post, it went viral. There was a patient who had said, my doc is going to the super expensive membership-based model. This person called it capitalism as a scourge to society. And I really think that a lot of the discourse after that Threads post led to a conversation around burnout. It led to a conversation around physicians like us on social media being vocal and talking about the problems within the healthcare system and the women's health system in particular and how it's been failing patients for many years.
Yeah.
What were your initial thoughts when you kind of came across that discussion as someone who does practice in a cash-based model as part of your work?
Yeah, I mean, I think that my initial thoughts to seeing that are honestly the thoughts that I have every single day because I feel like it is so clear to me, how much more joy I feel in the practice in my cash-based practice, purely just because it is just absolutely like the purest form of medicine. Like you get to spend time with people, you get to practice the way that you want to, not dictated by what a large system is telling you what to do. That control over your time and your practice of medicine is just so unique in our current system that I don't even think most patients realize how unique and special that is, that there's so much time that is spent, kind of controlling how physicians spend their time and how they spend their time with patients. And so that is amazing, but it also comes into direct conflict with the enormous, honestly, for lack of a better term, guilt that I constantly feel by operating a model where people have to pay cash to see me on top of the money that they're already spending usually on insurance, which is typically expensive. And, so I work in this other environment and I see patients who would never be able to afford to see me in that other model of care. And I also see the difference in those two different care models in terms of the actual provision of care that you can provide. And like I said, like it's an unresolved guilt within me because I want to be able to provide care in the way that I think is best for patients. And that is just unfortunately not possible in the system that we have built most of our healthcare system around.
Yeah, you really I keep thinking of this word distilled because in a cash-based model, I have a direct primary care practice. I understand what you're talking about. My patients pay a monthly membership. They have all their primary care needs with me. And it really is this very distilled down version of the quality of care and experience. It's so pure, right?
Yes.
It's a doctor-patient relationship, period, without all of the bells and whistles attached. Now, how long were you practicing in this other model you're in, right? Like kind of the traditional health insurance based system. before you then made that switch? Like, what was that tipping point for you?
Yeah, I mean, honestly, I'm not that far out of residency. So it's really only been a couple of years, that I was in that other model and I'm still there before establishing this practice, and so I think that, and obviously, before then, residency and medical school, and seeing kind of all of the failings of the system in other ways.
Mm-hmm.
But I think that for me, part of why I moved into this other practice was because one is eventually I really want to move in that direction just for the sustainability of my career. But also, I think particularly when it comes to menopause care, there is just such a lapse in the amount of time that we can spend with patients in an insurance-based model that in order to be able to provide the care in the way that I believe it should be provided, I think you have to exist in some sort of cash pay practice. Let me just give you a direct example, which
Please.
is that every single day, I have my own patients in the telemedicine practice, and I have my patients at the community health center. And I talk about menopause in both of those environments. Mm-hmm. When I'm at the community health center, I have quite literally had to fight to get more than a 20-minute visit to have a conversation with patients. And it is just not possible to have a discussion about menopause care in 20 minutes. Mm-hmm. It takes 30 minutes just to go through HRT, and particularly in all of the environment that we exist in with all of the myths and misconceptions that exist about that. So just to do the myth busting for HRT takes 30 minutes. And then I have that conversation in my own practice, and we talk for 90 minutes for our initial visit. It's amazing. It's such a cool thing to be able to do. And then the follow-up also allows that. And honestly, like I'm really interested in sort of how you approach this in a direct primary care model, because I really actually see the direct primary care model as such a perfect bridge in some ways between like a concierge practice and then the insurance-based model. And it's funny because even, for my patients at the community health center, there's almost, I think that there would be kind of this thought of people don't have the cash, they would never pay for a visit. But particularly, a lot of patients are coming from other countries. In a lot of other countries, fee-for-service medicine is just the norm. And so, I'll have patients who, I'll tell them, oh, I'm going to refer you to the specialist. I think that there's a copay. I don't actually know exactly what it is, but when you call, and they'll be like, no, I understand. I understand that I have to pay, $200 or whatever to see that doctor, but it's important to me because I'm trying to fix X, Y, and Z problem. So I think that even in that group of people, there is a lot more willingness to pay out of pocket for medical expenses, as long as you are getting the value from it. And that, I think, is the true failing of the insurance-based system, is that it's not providing the value for the amount of money that people are spending for their insurance.
Tell me, when you said, the number of people that you have to fight, like you have to fight to get these visits. I hear this from my residents too. Like residents that come and rotate with me in my DPC practice are obviously in a residence-based clinic in the academic setting. And they get, maybe 20, maybe 40-minute visits. And they notice as the years go on in their training, that number of minutes goes down. Maybe it's 30-minute visits, then it's 15-minute visits. And who are you fighting with? Who are you having these conversations with? And what is the conversation? Like, what's the pushback?
Basically, and to not throw too many people under the bus, from my other practice, but I think that, largely it is the administration and leadership of the community health center that, I think in some cases it's just a difference of medical opinion of kind of how that time should be spent. But largely in most insurance-based practices, it comes down to money. Right? That the way that the practice is reimbursed is by the number of people that you see. And I think that's something that people don't often appreciate is, I think that people understand, like when a doctor sees you, they put in some sort of insurance code and that's submitted to the insurance and the insurance reimburses some amount. I think two things that people don't really understand. One is that does not play any role in how the physician is compensated. So it's not like the doctor necessarily makes more money because they spent more time with you. Usually physicians are salaried, so they're going to make the same amount of money regardless of what happens in that visit. And so it's really about what is the practice trying to do in terms of being financially sustainable. And the second thing that I think people don't understand is that the cost that a practice is able to, or the revenue that a practice is able to bring in from insurance for a 20-minute visit is really not all that different from what it can bring in for a 40-minute visit. So it's not like it's like double the amount of money. So the practice really has no financial interest in having longer visits because the incremental amount of money that they get for that visit is less and less as the visit gets longer. And so in terms of the people that I have to fight with, a lot of it is just about that. It's just about, this is a busy community health center. There's a lot of people that just need to be seen. Community health centers are always struggling for money. And I would say that even private practices exist within that issue. And so, the only way that you can fill that gap is just to see more people. I was in clinic this morning. I was there for 3.5 hours. I saw 15 people, and it's like, how do you possibly
doing women's health?
Exactly. What? How do you possibly spend more than a handful of minutes? Because it's not just the time in that visit. You also have to sign all the orders. You have to make sure your note is done. You have to, check in with the pharmacist who has a question about, the prescription you put in. So it's like just unimaginable to be able to have the thorough conversations that a lot of people need for their health. And then obviously in my world, specifically related to the changes of menopause.
It's funny you said you have to sign all these notes. Like, part of why I wanted to call this show the Unsigned Note is because I hear this from so many of my colleagues that they're behind on documentation. They're like trying to keep up with charting for everything. And at the end of the day, the system is just so not designed to help us as physicians and healthcare workers thrive within it.
Yeah.
It is set up to make sure that we are doing so much more pajama time work later on.
Yes.
And so, when we go back to that capitalism as a scourge to society and relating it to medicine, and I think it's important we talk about why doctors are leaving the system, because I would argue the majority of us are not money hungry, people who want to go out and screw patients, right? Like the reason we're leaving is because we want to serve patients better and do what we were actually trained to do.
Yeah.
So, that doctor in that viral post, like those of us who are shifting toward a cash-based system, we're not cashing in. Mm-hmm, we're just trying to survive this very broken reimbursement system and practice medicine well. And that's just, like you said, the word sustainability, like that's just unsustainable. To live in that system. And that's why we're seeing doctors leaving medicine completely, not just leaving the system for a different model. They're just leaving medicine.
Exactly. And I think that also most of the time when doctors move to a cash pay model, they usually actually take a pay cut. And I think that, again, it doesn't immediately seem obvious that that is the case. But because, you see this price of $5,000 a year or $10,000 a year, I mean, obviously some concierge models are significantly more than that. And it is a lot of money. I'm not saying that it's not a lot of money, but if you think about just the costs of running a practice alone, like, malpractice insurance alone could be, $10,000 a year, depending on sort of what specialty you do, or maybe even more. And then, if you have a physical building, you have to pay the rent for that. If you have staff, you have to pay your staff, you have to pay the software for your EMR. So everything that is normally accounted for by the organization that you're working for, which is the one advantage of working for a big organization, is they take care of all of that for you. Now that's on you as an individual clinician to take care of. And so often by the time you account for all of the expenses that go into running a practice and the fact that you are inherently having fewer people, that's the whole point of prioritizing the quality of care over the quantity, you really are ending up at a situation where a lot of clinicians are making less than they did before, but they're probably happier because, like we started this conversation, you're able to spend that time in such a higher quality way with your patients and really get the outcomes that you want and that your patients want.
Well, I think that volume is just so important to discuss. Like in primary care world, most PCPs have 2,000 to 3,000 patients assigned to them on their patient panel, which is unfathomable. Like you're expected, okay, PCP, you need to handle basically all the frontline stuff, theoretically, that's how we were trained. And you have, 2,000 to 3,000 patients, no way. And so you move like I did to a direct primary care practice and have 300 patients. The math ends up with somewhat of a pay cut, but for a lot of us, the pay cut is well worth it.
Yeah, exactly.
I want to shift into women's health specifically, given that that's your world. And we see so much of women's health being, gravely impacted by our broken healthcare system. I'd like to talk specifically about your model and how you kind of talk on your website and in your Substack also about that first door, which is, the insurance-based model, and the second door, the other option, which is a cash-based practice. Speak specifically about women's health and how you see that, you alluded to it earlier with menopause, how you're seeing that, even if it's like examples, right? Like examples of things you've seen where patients have been impacted by less time, less
Hmm.
accessibility, less continuity of care
Yeah.
in the traditional system.
There's a litany of examples. I'll take like obstetrics out of the picture for one moment, because I think that that's a particular model of care, with obviously a very time limited episode.
Yep.
But the examples where I think I see the insurance based model failing women is in all of the conditions that we often talk about being ignored in our system. So the ones that come to mind the most, obviously menopause is the one nearest and dearest to my heart. But endometriosis, PMOS, formerly PCOS. These are conditions that I would make the argument, we often say these are really difficult to take care of, really difficult to diagnose. I would make the argument that it is really easy to diagnose endometriosis.
Yes.
You can really easily figure out who has
Yes.
endometriosis. You just have to know what to listen for and how to ask the right questions. And unfortunately, when you have somebody come in and they say, I get pelvic pain, and you only have 10 minutes to see that person, your reaction as a stressed clinician who has 15 people to see in one morning is just going to be like, okay, let's just get an ultrasound and maybe we'll talk about it in the future, right? Because you don't have the time to really sit down and say, okay, I want to go through your entire menstrual history. I want to go through where you're getting the pain. How do you get the pain? Do you get other symptoms? Do you get pain with sex? Tell me everything. And then not to mention the fact of doing a detailed pelvic pain exam afterwards to really make, a more keen diagnosis. So that is probably one of the best examples of that. But, menopause, where I see this come up is really, I think, very much in a primary care type environment, where you have a lot of women, they're in their 40s, their 50s, they're going to see their primary care doctor, they're having changes to their blood pressure, their cholesterol is going up, they have prediabetes for the first time. And they walk out of that visit on 5 new medications,
5 medications, yes.
to control that. And again, like it's, I'm not at all an anti-medication person. Like, these very much may be a part of the plan, but also can we have a discussion of, okay, well, tell me about the broader picture of the changes that are happening according with your stage of life. Are there hormonal things that are influencing that? Are we seeing that in other ways? What are the other ways that this is manifesting that we haven't even gotten to because you're not on the checklist of the things that we would screen for? So that's, where I really see this manifesting in women's health. And from, I think, just like a physician pride standpoint, like I think the other part here is that we see so much, particularly on social media, this distrust of medicine today. And I think that it is coming from the fact that people are increasingly going to their doctor, trying to get help, trying to get answers for something, and being brushed off, not because their doctor doesn't care, but purely just because they don't have time to fully explore that or to educate about that. And so then people walk away and they find the person on social media who says, I have the answer. This is all you need to take and it will fix your problem. And it's a very appealing message, but they're not getting it from, kind of the board certified educated source in the first place, because our system doesn't allow that.
The other thing the system that has done that's very interesting is keeping us apart from each other. And by us, I mean docs. Keep it like not the siloing of care, not only by specialty, right? So like you are a widget who handles this issue. So you handle this issue and then that person handles that issue. And you, primary care doc, your job is to send consults to all those people within our system so that we keep feeding this system.
Right.
But no one should talk to each other.
Right.
By the way, no one should talk to each other. And they keep us so burnt out and so disenchanted. And also, there's very little reward in the traditional system for the expertise you bring to the table, right? Like there's very little like recognition of that. And I think that people see that as like doctors have these big egos. And what you may not realize is we train for so long and take so much pride in what we do and do it well. And then to give us 7 to 10 minutes with a patient, we are going to fail. Like we're getting set up for failure. And when you set us up for failure, that's very demoralizing. And the further that someone's demoralized, the less quality of care they're going to be able to give. 100%. And I think that continues to just perpetuate. So that then it really leads to influencers being able to say like what your doctor isn't telling you, and your doctor doesn't care. when in reality, like, we care so much and we have been beaten down so much
Yeah.
that it's really hard to resolve that tension.
Yeah, and I think I totally agree. And the thing that I would add on too is I think that a lot of the ire that people direct towards the healthcare system is towards doctors or maybe medical professionals more broadly, but it's really just because we are we're the first face that you see, and there's an assumption that doctors are the representative of insurance companies. Doctors are the representative of pharmaceutical companies. Doctors are the representative of a big healthcare system, a venture capital firm owning a hospital, whatever it might be. And I get why that happens, right? Like, they're the person in front of you. It's like when you get mad at the representative on the phone, when you're trying to deal with something for your airline, something like that. Like, I totally get it. But I think what people don't appreciate is that often the doctor is fighting exactly the same problem that you have. Like, if you have some prior authorization issue, like, your doctor is just as frustrated about that as you are. And we are really on the same team. So it's not even that like doctors are kept separated, but I think like patients and doctors are kept separated because it facilitates the evil work of the powers that be to keep doctors as the bad guy, rather than really, having that anger directed towards the broader systemic factors that are actually making that relationship fraught.
I have a challenge question as we start to round things out here. Um, there is an equity problem, right? Like you mentioned, not everybody can seek a cash-based medicine practice, much like not every doctor can leave and create a cash-based medicine practice, right? But from a patient perspective, there's a systemic gap in who can afford good care, right? Good care.
Yes. Right.
Which, and that's an actual problem that's worth being angry about. Do you agree with that or disagree or poke holes in it?
I think that you can be a really good doctor in a bad system and still try your hardest, and I like to think of myself as a good doctor, and I think I try as hard as I possibly can in the insurance-based model that I take care of. So I don't necessarily agree that good care can only happen in a cash-based model. I think that that's important to say. But I do think that on a population level, looking at all doctors, all patients, there probably is some truth to that statement.
I'm so glad you said that. That's what I wanted to get to the nugget of, which is cash-based. People say a lot of times like, oh, you do direct primary care. That's not a solution. That's not the solution to the big problem. And none of us that are leaving that traditional system are saying we've got the only answer, but it's one of the solutions and one of the answers. And where that, the actual problem to be angry about is the systemic gap in who can access care, period, in the first place. And the fact that we have to pay such astronomical amounts of money to access care, but also worth being angry at the system that makes it really hard to have continuity of care, really hard to have access to care and time. So that I think is important to note for people who may not realize it. Those of us who are leaving, we're just trying to come up with a different solution. There are many solutions out there, and I think it's important to call that.
I totally agree. And, I put this in the piece that I wrote, but I think it's so true, which is that I really think that at the end of the day, it's the way that we have our healthcare insurance structured in this country that is the fundamental driver, not just of, these problems that we've discussed today, but really the inequity itself. That we already have a system where people who have more money get better care. And that is because maybe at a fundamental level, they have better jobs, which have better healthcare insurance attached to that. Or they have money and they can see a cash-based provider. Or they have money and they don't have to worry about the expense of a better medication, that just came on the market. So we already have that system in place. This is not in any way changing that dynamic that already exists. And so then if you think about it from that perspective, this is what I wrote. Insurance already is a membership-based medicine system.
Yes.
It's just a really shitty one.
Yes.
It's basically it's a membership that you are paying thousands of dollars a year for that, yes, grants you some emergency care, some really, a life-threatening, like very specialized care that maybe doesn't exist in like a DPC model. But it also is the one that gives you 15-minute visits once a year. You have to wait 6 months for it. It'll probably get canceled. It'll be hard to follow up with your doctor. And you don't actually get the outcomes that you want. And so I think that if we think about it from that perspective, it's let's change the way that we deliver our insurance in this country to make sure that everyone has a baseline level of high quality, affordable care. And then I think we can separate and we could say, okay, at the end of the day, we do live in a capitalist system. And regardless of what we do, people who have more money are going to get better care. There's literally no way around that. Every single country in the entire world, that is true. And so, but if we can at least make sure that everyone can have affordable care at the bottom, then we're at least operating from a place of basic equity is there. And then whatever else anyone wants to do with their money afterwards, we have no control over that.
Preach. Last thing, what is your unsigned note? Okay, the thing that you wrote or you wanted to write, but you weren't sure you could put your name on it, even if this was like back when you were in training, because it sounds like you've signed your notes since then, you know, the things that you want to say you're speaking out about.
Yeah, I in general, I think I speak out about the things that that I want to. I mean, I have literally a lot of unsigned notes in my chart that I have to fill out. I mean, I think that, you know, to me, probably, you know, the things that I think about the most that I still want to talk more about is how broader organizations that represent physicians really actually often don't do so in an effective way. And, you know, the American Medical Association is maybe the best example of this. But I just feel like we as physicians actually don't really have a very effective advocacy body. And in the process, we have seen these changes happen that have both led to physicians becoming more burnt out and led to less equity in the system. And I would love for our representative organizations that are supposed to be advocating for us as medical professionals to do a better job.
Maybe next time we should talk about organized medicine.
Yeah, let's do it.
I love that. Can you tell us where people can find you, talk about your own practice, learn more about you?
So I have a Substack, which you'll be able to find here. That's actually my favorite place for people to follow me because I just put the, you know, the most information there. And, you know, I think try to get into a lot of detail with all of these topics. I'm on Instagram, Dr. Jordan Niemann, or you can go to my website, drjordanniemann.com if you want to work with me clinically.
That's wonderful. And you can find me at Natalie Gentile, MD on Substack, on Instagram, on YouTube, and the same thing for my website. Lastly, if you're a physician that's watching this video who has an unsigned note of your own, send it to me. The link, you know, right at my Substack. I definitely will read every one of them. And Dr. Iman, I so appreciate your time. Thanks for this great conversation.
Dr. Gentile. This was great. I loved it.
This was
Anytime.
awesome. Take care, everybody.
Bye.
Have a good day.